Good morning. This is Doug Tynan. I'm the chair of the session on care transitions here at the International Conference of Integrated Care. This is a very important group of presentations that we're having this morning. And just before we get started, what we're going to do is have the presentations, which have been pre-recorded by video, but all the presenters are here virtually, and at the end of each video presentation, we can have questions from those of you who are listening to the presenter who was available in person. I am a health psychologist with a long history of work in patients, both children, adolescents, as well as adults, in integrated care, and also in my last full-time job was with the American Diabetes Association, was in care of people with diabetes. And as we know, in all countries, the increasing numbers of patients who have chronic non-communicable diseases such as diabetes, heart disease, renal disease, pulmonary disease, have placed great demands on our healthcare systems. And when those patients are hospitalized, transition to post-acute care is essential, basically to keep the system running. So without any further delay, I want to introduce our first presentation from Professor Lin Lin Hu from Peking Union Medical College on post-acute care in China, the development, challenges, and future prospects.
Hi, everyone. So the title of my presentation is Post-acute care in China, Development, Challenges, and Future Prospects. I'm Lin Lin Hu from School of Health Policy and Management, Peking Union Medical College, China. So there are three parts of my presentation. So first is the definition and significance of post-acute care. As we know, post-acute care, also referred to as intermediate or transitional care, it includes medical, nursing, and rehabilitative care for patients after an acute illness or hospitalization. So PAC is an integral component of healthcare systems. Studies have shown that increasing use of PAC can alleviate the burden on acute care departments, reduce hospital length stay, and the need for long-term care, such as nursing home services. And PAC is also associated with better patient outcomes, including lower mortality, lower readmission rates, and better functional status. And the demand for PAC is growing in China. According to the WHO Rehab Need Estimator, China has the highest unmet demand for rehabilitation globally. About 1/3, which is 460 million people, experienced a condition that could benefit from rehabilitation in 2019. And with population aging, the incidence of disease conditions that need rehabilitation increased greatly. So over the past 2 decades, China has released a number of policies to support the development of a rehabilitation and nursing care system in response to the growing demand for PAC. Since the implementation of the universal healthcare reform in 2009, China's health policies have emphasized the need to establish a continuous health system that integrates prevention, treatment, and rehabilitation. In 2012, the current Ministry of Health proposed a 3-tiered rehabilitation service network. And after that, a series of construction and management standards for PAC facilities were issued in the 1910s, and the government encouraged the secondary hospitals to transform into PAC facilities, as well as call for private investment in PAC system. And more recently, policy attention was given to home-based medical care for the disabled elderly people and patients with chronic conditions, which promote the development of home-based PAC services. So these are the policies we summarize in terms of to facilitate the development of PAC delivery system in China. But due to time limit, I will not go into much detail. And this is the structure of the 3-tiered rehabilitation nursing care delivery system in China. So as we can see on the top is the tertiary hospitals, including rehabilitation department in tertiary general hospitals or rehab hospitals, which mainly provide early and intensive rehabilitation for the acute patients or patients who are not fully stabilized. The second tier is mainly composed by rehabilitation hospitals, skilled nursing facilities, and secondary hospitals. And these facilities provide rehabilitation nursing care for those in their post-acute stable stage. And the lowest tier is mainly community health care institutions and some community-based rehab and medical centers and nursing centers. And they provide a long-term rehab and nursing care for those in their chronic recovery stage. And for financing and payment of PSA, in China, the reimbursement of PSA services are mainly under the basic medical insurance in China, but the coverage of PSA service items is still limited. And until now, there are only 29 rehabilitation service items that are covered by basic medical insurance. And the payment method of PSA are not separated from the payment system for acute care. So there are mainly 3 types of payment method for PSA services in China now. So the first is fee-for-service, and second is DRG, and in some areas they adopt a simple per diem payment. So these are all have some disadvantages and are not suitable for the payment of PSA services. So it is worth mentioning that there are some emerging innovative payment reforms in some areas based on FRG or PDPM now in China, but they are all in their initial stage and need further assessment and research. So in the last part, I will talk about the major challenges and that faced by the PSA system in China and some future recommendations for further development. So the first challenge that the system faced with is the unbalanced development and lack of coordination in the hierarchical PSA system. So as I just mentioned, a 3-tiered PSA system has been developed in China, but the infrastructure and resources at each level are insufficient to meet patients' needs. So this is particularly due to the inadequate public investment. So although there are a large share of public investment in public healthcare facilities in China, but most funding has been directed towards the expansion of large national or regional medical centers, and with little going to PSA facilities. And care coordination mechanisms is very weak in the 3-tiered PSA system. Currently, the coordination between the 3 levels are mainly driven by administrative orders or compliance, and rarely by incentives. So the second challenge is the lack of clinical guidelines or standardized practice in PSA. So in China now, most hospitals provide inadequate or no coordination with the aftercare institutions. So the patient-nurse relationship usually ends at the time of acute discharge, and the nurses they either lack relevant knowledge or are not assigned responsibility for continuity of care or transitional care. And existing policies have not stated the admission criteria of PSA facilities, as well as the goals and content of PSA services. So this limits care coordination between different levels of care and prohibited standardized practice in PSA. So the third problem is the limited insurance coverage and low reimbursement price. So as I just mentioned, the basic public medical insurance coverage in China is insufficient for PSA services, leaving individuals to bear the full cost of many common and effective rehabilitation services and face high cost sharing for those PSA services that are covered. And the fourth problem is the improper provider payment methods for PSA. As mentioned earlier, the current PSA payment is mainly fee-for-service or DRG system. So these payment methods are often incompatible with the characteristics of PSA. So fee-for-service incentivize healthcare facilities to maximize the amount of services provided, which can induce waste or low value care. And the guarantee system provides hospitals with incentive to shorten the length of stay, which may affect the quality of PSA because it typically requires a longer period of hospitalization. And the fifth challenge is the shortage of professionals and training programs for PSA services. So China currently has a severe shortage of PSA workers, including rehabilitative specialists, therapists, and nurses. And China is also facing difficulties in the training and retaining of these professionals due to lack of professional titling, specialty classification, and a clear career path. And the last challenge that China faces is the underdevelopment of a unified patient assessment tool and information system. So currently, there is no unified or standardized post-acute assessment tool in China. Different institutions, including rehabilitation hospitals, skilled nursing facilities, community health institutions, and home care agencies, they use different tools to assess patients, making care coordination and quality control very difficult. So these are the major challenges China faced in the development of the PSA system. So based on this, the analysis of the progress and challenges, we have some recommendations or future outlooks for the further development of the PSA system in China to form a more integrated and holistic healthcare system in the future. So the first one is to consolidate and integrate the three-tiered PSA system. So the government should increase the public investment in the development of the three levels of PSA facilities. And also the policies should be established to facilitate investment from the private sector. And the three-tiered PSA system should be integrated to promote care coordination across different types of PSA facilities and ensure patients' smooth transition between different levels of care and efficient use of PSA services. The second is to raise awareness of the importance of PSA and develop clinical guidelines and standards of care. So because China's medical system has traditionally focused on acute treatment, and the post-acute phase of rehabilitative and nursing care has been given less attention. Thus, it's important to raise awareness among the public and healthcare workers about the importance of PSA for optimal health outcomes. Clinical guidelines should be established to outline the types of services that should be provided at different stages of recovery and in different settings, as well as the goals of the care. So the third recommendation is to reform the financing and payment of PSA. So besides expanding the public medical insurance benefit package for PSA, China should consider adopting payment methods that are more tailored to the needs of patients receiving PSA, such as function-based payment method to incentivize more high-value PSA service. So the fourth recommendation is to establish health provider requirements and strengthen the training and retention of professionals. This is to address the shortage in PSA professionals. So China could consider establish some professional training system and some supporting policies for rehabilitation specialists, therapists, and nurses, including the development of a professional licensure and classification to differentiate and regulate the workforce. So the last one is to build a unified information system for PSA based on functional assessment. For evaluating patient health throughout the hospital discharge, PSA admission, and care processes. So such a tool could be used across PSA facilities, based on which a unified information system could be developed to provide continuous assessment and record keeping for patient care to improve care coordination and enable quality monitoring and evaluation and ensure fair reimbursement. Okay, so this is my presentation on the development of China's PSA system towards a more integrated and continuous healthcare system to facilitate patient-centered care and integrated care. Thank you for listening.
Okay, thank you for that very concise, thorough presentation on a very large problem. Are there any questions for Professor Yu? No questions, no comments. Any comments from any of the other panel members?
I do have a question for Dr. Yu. I wanted to ask, I was looking at the chart with the various non-communicable diseases, the prevalence of that chart, the prevalence of diseases on that chart. I just wonder, given the state of where the rehabilitative system is and the various absence of enablers that are required for a stronger population-based approach to rehab, do you have concerns just given the kind of the changing demographics that you're anticipating and as any patterns around disease prevalence over time?
I'm sorry, so your question is about how the PSA system adapted to demographic change, like?
I'm actually curious, given the state of where the rehab system is right now, and given any concerns of the changing demographic patterns for China, do you think that the system is going to catch up enough in time to address any population health profile changes that is anticipated?
Yeah. I think basically the rehabilitation system, more and more is acquiring attention by the government as well as the industry. So that the basic driven factor is population aging and the change in epidemiology transition. So because there are more people there have the chronic condition that could benefit from rehabilitation, as there are a large population with chronic disease in China, and the biggest older population in the world. So it is acquiring more and more attention, and the system is getting bigger in China. And also there are some initiatives on the financing and payment side for the rehabilitation and nursing system in China now. I think that is in response to the demographic change and the high incidence of chronic disease currently. And so for the three-tiered PSA system I introduced just now, so the first on the top is the tertiary level, and which will focus on the patients in their acute stage when they're not very stabilized, but it's small part. Then the second tier is for patients in their stable stage, and to provide professional rehabilitative services. And the baseline is the primary level PSC services, basically provided in the communities and homes, and it constitutes the largest part of the PSC system. At least in our design, it should be the largest part. So the home-based care and community-based care is developing very quickly in China now, and to meet the needs for the older population, because they reside in the communities and homes largely. So the system design is also in response to the need of the aging population.
Thank you.
Thank you.
Okay, thank you.
Mhm.
And I don't see any other questions, so let's move on to the next presentation from Dr. Katharina Kovacs Burns, the Senior Provincial Consultant at the University of Alberta in Canada, where hopefully the fires are dying down. Let's go ahead and proceed.
Hello, everyone, and thank you to the conference organizers for having us present on the understandings of managing fragmented transitions in care today. I'm going to be talking a little bit about some of the experiences we've had with patients' families, care providers in our system before, during, and follow up to COVID. So I am Kathy Kovacs Burns. I'm the Provincial Senior Consultant within Alberta Health Services in Clinical Quality Metrics, which really means that I do a lot of measurement around different experiences with different groups in different settings and work towards quality improvement using those measurements and data to help guide that. My colleague who couldn't be here presenting with me is Marianne George. She is a provincial patient family advisor, and so brings a very important perspective or lens in terms of the co-design work and also the involvement of patients and families all the way through our work. This is our context. It's Alberta Health Services. It is Canada's first and largest province-wide fully integrated health system. So what I will do is to actually present a little bit about the co-design approach. It is an approach that's favorable to us in terms of our work. It involves diverse teams and allows us then to be able to look at measurement in a more comprehensive way for quality improvement. We'll talk a little bit about some of our findings, sharing a case example out of our initiative that comes between COVID or during COVID, and some of those results that we can share with you that's broader than just the example. And then talking a little bit about the impacts of COVID-19 and what it did in terms of not just our study, but how we look at measurement, particularly transitions in care services for patients and care providers in our system. So our design aims, well, our study really in 2019 focused on the real-time experiences of patients and clients and care providers regarding their transitions journeys. And then when COVID hit, we decided to look at what happens in terms of those measurements and experiences before, during, and now coming out of COVID. We originally had 11 acute care and community-based settings that included long-term care, home care, and other types of mid-transition types of settings. This is within 5 zones of Alberta Health Services. These were self-selected sites as part of the pilots study. So 2019, we began to work with 11 sites. We wanted to explore and monitor transitions in care in a broad sense, looking at the experiences, including challenges, successes, and using that data to actually then look at pre and post quality improvement initiatives around transitions in care. But then when COVID hit, we also wanted to examine the impact of COVID-19 on those transition and care experiences and some of the outcomes it had, not just at the micro level, which is the patient and family experience level, but also meso, which is healthcare practices, services, healthcare provider experiences, at the macro level too, which is really the policies and the practices that drives how transitions of care would be delivered and operated, coordinated, integrated across the system. So as I mentioned, we use a co-design approach. This is our approach. We have 4 phases within that approach. We always begin doing orientation, planning and preparation with the diverse teams at the studying sites. And there we then co-design or co-develop our tools and measures around what we're looking at. In this case was transitions in care specifically, but it also involved the other experiences with other services and care providers. We would gather that experience measurement data in real time. In other words, before COVID-19, we were at those studying sites. Family advisors would speak to patients and families in person. We would go out and talk to healthcare providers in person. During COVID, of course, that changed to a virtual environment. I'll talk more about that. Once you gather the data, of course, we wanted to use that for quality improvement initiatives and strategies, and then gather post-quality improvement measures to see what difference those interventions made in terms of those experiences, and then discuss what worked, the challenges, feasibility, sustainability, and particularly capacity building at those particular sites. So some of the results during our phases, and certainly before COVID, as I said, we sort of had that approach in place when COVID hit, and between the waves of COVID, we tried to sort of move forward again. But as COVID was in progress, there were lots of restrictions, so we really could not do what we wanted to do originally, and we had to make adjustments on the fly. Now, initially, we did do a scoping review of the literature to find out what measures existed in transitions in care. We found that there was a lot of terminology that was quite different, depending on population, depending on settings, how people were viewed transitions of care. So they included things like coordination of care, integration of care, continuity, along with some of the transition experiences. And the literature was actually scarce on this, so we had to actually develop a lot of things ourselves. We developed a care transitions journey map to see what we were mapping and where transitions journeys might happen. I'll share that with you in a moment. And then we developed some general core transitions and care experiences, the processes, and looked at outcomes or impact. And those were related to looking at domains, indicators, and specific measures at the micro, meso, macro levels. And of course, we wanted to look at what impact COVID had on all of us, all of these journeys. Here's our transitions and care map, as complex as it is, but it certainly isn't everything. I mean, different settings have different acronym type maps and so forth. So we wanted to look at where people started in their journey. It could be at home, it could be in the emergency department, acute care setting, primary care, and then where in fact they actually traveled or how they transitioned from one place to another or with different care providers. And so that was a personal journey mapping of patients. But on the broader sense, we wanted to look at where our measures might fit for those core domains and measurement. We started looking at fishbones, and I know this is a busy slide, but many of you probably work with fishbones when you start to identify where the issues are when you're mapping journeys of patients and their experiences. And so we did that. We outlined a fishbone, looked at the issues, see what the measures were from the literature or other sources within our own jurisdiction, and then started to theme them. And so that's really where we would start to see how these things mapped out by domain, indicators, and measures. We added in, of course, the complexity of COVID. And that brought in the policy and administrative kinds of measures and domains, the leadership measures, the things that would affect processes for transition, and ultimately what might impact the experiences of patients, families, and of course, healthcare providers in delivering transitions of care to patients. And so this was also mapped in as part of the fishbone. And it ended up looking like this in terms of some of the core transition measurement areas. As I mentioned, we looked at the pre-COVID and then really wanted to see if our domains might alter a bit or expand a bit during COVID and coming out of COVID as we live with COVID and other experiences today. So of course we had to include the virtual context along with the in-person. We had some lessons learned through the pandemic, and these were some of the main ones, of course. So during the pandemic, we had to do reality check-ins constantly. So before COVID, as I said, things were opened up. We were in long-term care settings, home care settings, acute care settings. And then as COVID hit, the lockdowns happened, restrictions happened. We were challenged then to understand how we were going to map transitions in care with patients and care providers, knowing, of course, that transitions still had to happen during COVID, regardless of whether the pandemic existed. People still had to be transitioned. And so we looked at what that might look like and how that reality check-in was going to then map out for us. We had to adapt our work from the virtual and restricted environment, considering this redeployment of staff. And so our teams got smaller. But that meant too that patient family advisors would be talking to their patients and family advisors and home care settings or the mid-transition kinds of programs virtually through Zoom and through phone. What was those limitations look like? Now, we found it pretty positive, generally speaking, but that was a reality check-in, and it was a learning on the fly. We had consideration for possible changes in the measures, as I mentioned, because sometimes what you measure during normal times, and there's policies in place and transitions are smooth or smoother, even though there's still fragmentation happening, you could capture those journeys a little bit more clearly in the settings that you are actually in during that time. And so we had to measure what was changing from the pre-COVID to during COVID, and then now as we're coming out of COVID, what is going to be kept in terms of those measurements? What's going to happen with our tools? Will they still be the same kinds of domains, same measures as a core? What will change around that? What did we learn? And then, of course, the virtual co-designing aspect. That was a very interesting experience in itself. Turning everything from in-person into virtual, using that environment to continue with our orientations, our planning process, our data gathering and analysis, and then moving into quality improvement measures where we could. So this was really an interesting journey. And we had to start somewhere. We understand there was a baseline, and then we would actually then move across settings and look at that impact that the pandemic had within those particular settings. So pre-COVID, we had 11 sites, and that included acute care. During COVID, we were restricted in acute care, so we couldn't do too much there, but we still had staff telling us or informing us how those transition journeys might happen. Most of our journey was in the home care setting with clients as we virtually connected with them, or the mid-transition kinds of journeys that people would experience. So here's an example of a mid-transition program site that I want to share with you. So this is a program that's not fully, people weren't transitioned to long-term care or necessarily where they're supposed to be after transition. This was mid. So it's just sort of a program in between, but it allowed patients' families someplace to go and allowed staff to actually transition people out of acute care emergency departments in the meantime. So this is one of them. Now, you can see here that 90% of clients' families did not feel that COVID actually impacted their communication, which was one of our core measures, or discussion, their assessments, their preparations to get into this particular transition program. Staff, on the other hand, felt, a lot of staff felt, that the COVID changed the assessment and admission for clients, excuse me. It presented with delays, it limited staff from looking at program options. The virtual discussions sometimes were difficult to arrange, a lot of things that they saw. So there was a discrepancy in terms of their experiences and their views. Now, before and during COVID, so here was a congruent part. Both a lot of clients and staff said that the program or activities had changed because of COVID. So the programs themselves had to change. They realized that was a reality as part of COVID. But as I said, the clients or patients and families felt little impact in terms of their transition between hospital ER and coming back into this program and being part of it. So that was a good thing. On the other hand, staff did not feel quite so confident. They felt that patients needed more supports. Their capacity to self-manage decreased. Sometimes they regressed a bit. There was decreased attendance, sometimes with virtual, changing from in-person to virtual. And one of the quality improvement pieces was to make sure that they maintained communication and enhance that, and sometimes to do home visits. So the in-person was important. And that's what you see in the last piece. The positives to keep, virtual care wasn't bad from the patient perspective, but they loved the home visits and appreciated those. Pharmacy services were good, nursing and medical care was good, family care conferences were great. And those were similar positives on the other side when we saw the case manager doing pre-assessments through home visits, family care conferences, and the transition process was a bit more positive when they initiated some quality improvement strategies. Overall satisfaction, you can see the difference here. So 83% of patients' families gave it 8, 9, 10 out of 10 scoring for overall satisfaction, whereas 75% of staff were satisfied with this program and program delivery during these processes and the adjustments that had to be made. So we continue our work now as we sort of open things up. And this is one example, but home care kind of clients and care providers had similar kinds of experiences. And so we're noting that and building our domains of measures and making sure that those are the core. We will be publishing on that, I think, because it is something that is quite unique coming out of this process. We are going to be continuing to assess the impacts as we move forward, looking at the new norms as we come out of COVID and the resulting experiences, not just at the macro, micro, and meso levels, in other words, with patients and care providers and those services, but also the macro levels. what's the policies, the policy changes, how are they evolving now coming out of COVID, and how is that going to impact practice and policies as we go forward. So we are continuing to evaluate that now as we come out of COVID, expanding our dimensions and including transition services across Alberta Health Services and the different settings that are going to be explored across the 5 zones. So we have a lot of people to thank for this initiative and the work that's continuing and the work that we did from 2019 into COVID. So thank you very much for having us present. We're always open to questions, and we share the study, and look forward to having more discussions with you on this.
Thank you. That was, again, a great presentation on a critically important topic. As we were discussing with the panelists before, this post-COVID era is very unknown territory, and this project in particular is giving us some guidance, or is going to be the first set of data. So any questions for Dr. Burns?
See a hand up? Go ahead.
I see hand up. Go ahead.
I don't want to take away from the audience, but if there's no one in the audience, I wanted to ask Katharina, very interesting information from Alberta in terms of pre and during. In Ontario, we are moving towards that central health authority, but different authority, different responsibilities, obviously. I'm actually really curious, given that AHS, actually controls a lot of its, components of the healthcare system. What has AHS learned about its operations around transitions and care during the pandemic, and what will be changing now that we're kind of moving into this, easing up and post-lockdown COVID world?
Yeah, very good question. And I think we're still exploring some of that for sure. But there are a few things that we have learned that certainly there has to be adjustments to policies because it's now critical in terms of our understanding that virtual care is here to stay, and it will be embedded in terms of the healthcare system and all processes, including transitions and care. It's not always necessary to have in-person types of, the different assessments or indices used and so forth. So I think we've learned that as probably something that will be here to stay. The other thing that we learned in the process, and you saw the sort of the mapping of experiences, but we saw that some of the in-person kinds of follow-up did not have to stop during COVID. That when you have measures in place and there are guidelines and restrictions that sort of guide the visits, the home visits in particular for different populations from transitions, to make sure that there is proper navigation, that the challenges between going from one site to the other is actually addressed so people don't fall through the cracks. Sometimes you need those in-person kinds of components. And so some of that is going to be something we'll build on, that we'll build in the virtual, but the in-person kinds of assessments to make sure that people transition, whether it's a mid-transition program, because not all people can be transitioned immediately to a full placement or a clear understanding of where they're going to be, whether it's home or home care or long-term care from acute care or emergency departments, or maybe to another unit or a rehab facility. But sometimes that mid-transition, so we've learned that mid-program is an important one, and we're building on that, I think, learning from that opportunity, because patients and even staff felt that was a gold mine. It relieved the pressure, helped a lot of things. So those were some of the things that we learned, but we're learning a lot more too about what's going to evolve out of the domains and the measures as we go forward, and we're building on that now as we come out of COVID. So thanks for that question.
Thank you. Great presentation.
Okay, another question from Nancy. Go ahead.
Thank you so much. It was really interesting to see the difference in the experience ratings between staff and clients. And as the non-academic on the panel, I think it's interesting to look at those pieces through COVID and to learn from those. Not surprising at all People were doing cartwheels in the background to try to make things work. But what a testament to the program that the clients weren't experiencing that what they were experiencing was this beautiful kind of seamless transition despite what was going on in the background. It was just an observation from the data. My question was whether you saw any different needs identified or clusters of needs identified through COVID because of the isolation. And are those things that you would sort of continue as you build your program?
Yes, absolutely. There were things that were identified, and it wasn't always identified by the patients and families or clients and residents, by the way. Sometimes the staff saw that there were needs that needed to be accentuated. For example, they did say that, you know, clients needed a little bit more supports in certain kinds of areas. And how do you bring that in if you can't bring in physio or if there's restrictions? But, you know, we also learned from family visits that, you know, again, those needed not to be as restricted as they were, but because that meant that it took away from the families in terms of coming into acute care settings, helping with that transition, et cetera. So I think that those needs, some of the family needs, of the, you know, the communication, information, the transition kinds of packaging that needs to happen is something that too was definitely seen as needing to be escalated. And we're doing some of that work now in terms of the hospital or home to hospital to home kinds of pieces, as well as, you know, trying to make sure that we address even the staff needs in terms of what resources and things do they need to know, the coordination of care, what's out there for them to transition people to, how is that going to happen with patients and families? So the bundling of kinds of activities and supports. So that was definitely seen as something that needed to be there and needed to be escalated. Communication was a big one. We need to escalate communication at all levels. That's something we learned. Proper communication is such a tool, an important tool that actually minimizes anxiety, stress, even for healthcare providers. I mean, once they sort of talk things through and patients understood, with sort of less stress in terms of what was going to happen next, direction, information. So it's sort of that in-between piece between point A to point B or between care providers that I think we're building on. That's the need that has to be, I think, escalated. We're learning a little bit more about why that's not happening, where the challenges are, how can we bridge that a little bit better to make coordination and integration better. And then, of course, the experiences will be more positive. There'll be reduced hospital readmissions, reduced emergency visits as well. So I think those are some of them. So we're learning quite a bit from that, but without those experience measurements at all levels, we're not able to connect the dots. So that's important, I think, from the work that we're conducting.
Thank you so much. Excellent, excellent presentation.
Thank you. And my other comment on the presentation is thinking at it as a psychologist is what you're doing by providing more information in a platform that patients can identify with or can use is you're reducing anxiety. Whenever you reduce anxiety, you reduce emergency department visits.
Yes, absolutely.
People are scared and anxious. That's where they go. So thank you.
That's right. Thank you.
Message. Hold on a second. I'm good.
Sorry, that's just a comment to you.
Okay. All right. All right. Let's move forward. So we're going to leave Canada for a moment and move to Andalusia. Dr. Rafael Rodriguez-Acuña is going to be talking about improving healthcare at home for complex chronic patients in a independent regional project in Andalusia. So let's go ahead with that recording.
Hello, good afternoon. First of all, I would like to express my gratitude for this opportunity to present the study that has been carried out in Andalusia, an activity in the framework of the JADECARE Joint Action. My name is Rafael Rodriguez-Acuña, and I'm Project Manager at the Andalusian Public Foundation Progreso and Health. This study also has involved colleagues from the Regional Ministry of Health and Consumer Affairs of Andalusia and the Andalusian Health Service. In this presentation, I will start with an introduction with a specific reference to the Andalusian context and the European Joint Action JADECARE in my region. Then I will present the methodology used, the results, and I will finish with some comments. Andalusia is a big region located in the south of Spain. In Andalusia, there is a public healthcare system responsible for the provision of healthcare and public health services to the entire population of the region. The system is a wide network with two levels of care: primary care, which forms the backbone of the system and is provided in 1,500 primary care centers, and specialized care, which is available in 50 public hospitals, including specialists of patient care. With a population of 8.4 million inhabitants and a life expectancy reaching on average 82 years, Andalusia faces a rapid increase in the population living with chronic conditions, which puts a high pressure on health system. Therefore, multimorbidity has become one of the most important challenges for our healthcare system that must be tackled. In this context, around 404,000 complex chronic patients, that is, patients with chronic severe health problem, multimorbidity, and polypharmacy, were identified in 2022. Among complex chronic patients, patients with chronic heart failure and COPD have been prioritized. Moreover, have been also prioritized those complex chronic patients that meet the following criteria: recent hospital discharge, being in a clinical situation of instability, decompensation, or at risk, and require immediate response and subsequent continuous monitoring. In total, they represent 50% of the complex chronic patients, around 200,000 patients. The use of information and communication technologies for following or monitoring the health status of patients while they are at home is a promising approach. In recent years, there has been a growing number of studies on the use of telehealth in the management of patients with heart failure and COPD, providing data to suggest that it can facilitate patient follow-up, avoid severe emergency episodes, improve patients' well-being, and promotes patient empowerment. However, there is limited evidence on their effectiveness in real-life conditions, so further research is still needed in the field of multimorbid patient management. Within this framework, the Joint Action JADECARE was launched in 2020 to face the challenges of the transformation of health and care in Europe. JADECARE aims to reinforce the capacity of health authorities to address the health system transformation, in particular, the transition to digitally enabled and integrated person-centered care, and support the transfers of best practices from the originators to the next adopters. For this purpose, 45 organizations from 16 EU countries participate in JADECARE, where 4 proven good practices have been implemented by 21 next adopters. Andalusia's participation in the project is coordinated by the Regional Ministry of Health and Consumer Affairs of Andalusia, together with the Andalusian Public Fundación, Progreso and Health, and support by the Andalusian Health Service. The JADECARE methodology aims to serve as a guide to facilitate the implementation, adoption, and sustainability of good practices. It includes 3-phase implementation strategy to be followed by all implementation sites. These phases are pre-implementation phase to develop the pilot action plans, implementation phase in which the pilots are implemented and monitored according to the plan, do, study, act cycle approach, and post-implementation phase to analyze the results and the implementation process itself. Thus, after a feasibility and relevance analysis, Andalusia designs a good practice inspired in the COPD component of the Danish one called digital roadmap towards an integrated healthcare sector. Our good practice is named Improving Healthcare at Home for Complex Chronic Patients, including proactive follow-up in Andalusia, and is aligned with the Andalusian strategies and plans. The aim of our good practice is to improve the health status and quality of life of complex chronic patients by improving home healthcare and its proactive follow-up. The target population are prioritized complex chronic patients in Andalusia at primary care level. In a nutshell, to evolve from a reactive healthcare model to a proactive follow-up one. Our good practice includes three components: the centralized system for proactive follow-up of chronic patients that includes its development and integration in the corporate IT system, DIRAYA, allowing early identification of warning signs, adaptation of prescription, anticipation of health problems, avoiding unplanned inpatient episodes, and so. The teleconsultation system for interprofessional referrals between primary and specialized healthcare for chronic patients follow-up to improve the continuity of care between healthcare levels and a better coordination among healthcare professionals, avoiding unnecessary patients' travels. And monitoring system for the assessment of the corporate system for improving healthcare at home. Now, I will show you a brief overview of the main results. Compared to the baseline situation, that is, without intervention, a decrease in primary care visits and outpatient visits was observed. On the contrary, a significant increase was observed in home visits and, to a lesser extent, emergency episodes. This may be due to the complex health status and the frailty of these patients. However, comparing to the situation of the target population before and after the implementation of the proactive follow-up and the teleconsultation system, a significant increase in home visits was observed. On the contrary, a decrease in outpatient visits was found, a greater decrease in the case of patients with proactive follow-up. The two main conclusions are: the evolution of the model from a reactive care to a proactive follow-up approach leads to a significant increase in primary care home visits and a reduction of outpatient visits. The sustainability of the practice is guaranteed since it is embedded in the long-term plans and strategies of the Regional Ministry of Health and Consumer Affairs of Andalusia and the Andalusian Health Service. However, the transferability of the good practice should consider that the pilot took advantage of the existence of a regional public healthcare system with universal coverage, which has plans and strategies addressing complex chronic patients and their needs, as well as the massive use of the corporate IT system, DIRAYA, available at all levels of care, facilitating the registration of information and the retrieval of data for assessment. Internal limitations include unexpected issues emerging during the integration of the centralized system for proactive follow-up in pre-existing corporate IT system. This caused a delay of 6 months. Also, the new system is expected to be operative in early summer. For this reason, surrogate data from alternative proactive follow-up service in place was considered, not affecting teleconsultation data. Moreover, I would like to point out that all these initiatives have been made possible thanks to the financial support of the Spanish government through the Red.es initiative, the Andalusian Health Service, and the JADECARE project. Last but not least, I would like to thank our team and all the other professionals who made possible the development of the practice and the implementation of the pilot in Andalusia. On their behalf and on my own, thank you very much for your attention, and now I'm open to your comments and questions. Thank you.
Thank you. Again, another presentation on the importance of planned follow-up care. All of us who have worked in healthcare settings have I know I've certainly experienced the situation where a patient gets discharged without a clear plan, and inevitably that often results in a readmission, an unnecessary readmission. So any questions from our panelists or attendees? I'm not seeing anything from the attendees. Anyone on the panel? I know, I'll just ask an administrative question. I know in Spain there are separate autonomous regions. Are there any other regions in Spain doing anything similar to this?
Yes, I think that there are several regions autonomous that are making similar efforts to promote telehealth in the follow-up of patients.
Okay.
Well, I would like to recall that tomorrow morning there will be a special workshop on the JADECARE project for those that are interested in more information about this EU project. So in the workshop, they will be shared the result of all the project, and also they will be explore the key elements to ensure the sustainability of the local good practice beyond the project. Of all the, I mean of all the project, not only the Andalusian or the Spanish one, of the 21 EU participant entities.
That's great. Okay, so a workshop tomorrow. And then Nancy had a question, comment.
Thank you. Thank you. I was really interested to see the data on the increase in home visits. I was curious from a funding perspective, is your fee schedule then, does it have embedded in it permanently the ability for primary care to do those home visits and to then be remunerated appropriately for those visits?
Could you repeat, please? I don't understand you very well.
Sure. It's really a funding question, and a piece we struggle with in Ontario, that it is difficult for us to have primary care go into homes because the fee schedules that doctors are paid or nurse practitioners are paid don't necessarily accommodate the time and effort that's required to go into the home. So I was curious if that kind of process was embedded into the payment for primary care.
Well, we have, I have to point out that we are in the framework of the public healthcare system that is paid with the budget of the government. So all the healthcare system is provide, well, 98% more or less of our healthcare system, of the healthcare providers are civil servants. So in the schedules are include the visits, the home visits. So this is the reason, because it's important to remind that that we use a massive the massive use of IT systems, because it's all the same system to the whole territory, and the whole all the primary care centers and all the hospital share the same system. So it's easier, it's more easy for us to go homes of the patients, take data, and this data are stored in a corporate database. So in the next visit, the doctor, it doesn't matter if it's in the same municipality or in the same city, have the same information. So for us, it's more or less easy to control this factor. However, it's interesting that for me that you make this kind of question, because for us it's normal. We have in our healthcare system, we have some appointments that are scheduled for home visits in the day work. It's not a special issue. It's for us, it's part of our daily work.
Very interesting and very important context. Thank you for that.
You're welcome.
Thank you. Well, I might as well bring it up here because everyone could respond to it. Whenever I hear home visits, I often wonder about home visits for what purpose. That there's potentially medical home visits, but the nursing is more common. Sometimes we have home visits just to make sure people's basic needs are met. Is the housing appropriate? Is food appropriate? I also have concerns, particularly I'm in the northeast part of the United States where a lot of the housing is 2 and 3 levels. When we have older people, the probability of falls, which is one of the major causes of older people falling and either having fractures or other things. And so there's an innovative project just north of me in Philadelphia where they sent an occupational therapist or a community health worker just to take pictures inside the house to make sure the bathrooms are set up appropriately with rails and how many steps are there. And in some cases, really to counsel the patient on perhaps moving to another location that's a little less hazardous. So I didn't know if any of these programs are looking in that level of depth, particularly with older geriatric populations, of looking at the physical structure of the home and to try to prevent unnecessary injuries.
I could
Here in
comment.
Spain,
Oh, sorry.
we have,
Go ahead.
sorry.
Yeah, I'd love to hear a comment. I'm just being provocative.
In Spain, we have, well, in Spain, in my region, we have some incentives from the government to trying to solve this kind of barriers, trying to avoid steps to the access to the buildings, and also giving incentives to build lifts in the older buildings and so on, to facilitate that the people can access or leave their home when they want. In any case,
Great. There was another comment. I heard a voice.
Yeah, that was me, and yeah, I agree. I think this is very important. I think as of late, we've been building in the social determinants of health very solidly into a lot of assessments. So, everything from housing to transportation to all those, even some of the language and literacy levels of people, to try and understand what is going on and who they can contact. And so I think a lot of those pieces now are starting to be embedded, and it is extremely important when we talk about home visits. And we found out even during our studies that patients or residents who really did not understand very clearly or had a language barrier needed to have specific people actually do home visits. So it's not just sending out anyone, actually, right? So I think, because you're asking very important questions about their mobility. So how do you do mobility checks if you can't do a home visit? How do you do those assessments? So I think it is becoming more important. I think that's why we realize we can't turn everything into virtual visits.
Correct.
So that is, I think that's really becoming part of the things that we're really looking at exploring far more than we ever did before.
When you're doing a virtual visit, you're not climbing the steps. You don't know how cold it is inside, and you don't know what the place smells like. So you lose all that sensory data. What we have is visual and auditory.
Right.
Okay, thank you. That was, again, I'm always struck. I've been involved with the International Foundation Integrated Care for about 10 years now. I'm always struck when I go to these meetings. I get so many ideas. Just seeing different professionals around the world working with different populations, but often dealing with the same problems and looking for the common features. And the other thing I first came to IFIC was the first conference I went to integrated care was clear, meant integration of social care, social services, housing, transportation, food with medical care. And I came from an American system where we were talking about integrating health and mental health. And over the years at IFIC, I've seen that mental health gets pulled in much more than it used to be. And then integrated care really means looking at all the domains of influence on health, mental health, as well as the social factors. Our next speaker is Dr. Siu Mee Cheng, also from Toronto, the executive director of Street Haven, which I did look up yesterday. She reminded me in the chat today, but I did look it up, which is a women's multi-service agency in Toronto serving women who are most vulnerable with chronic diseases, potential homelessness, and mental health problems. And she's going to do a presentation on hospital to home, the logic, model, and theory of change to identify outcomes of integrating what I just talked about a moment ago, healthcare, social care, and I also do carve out mental health as someone that we need to specifically include. So let's see the presentation by Dr. Cheng.
Good afternoon. We're excited to share some important foundational work that we are doing to understand the impact of an integrated health and social care model on safe and effective transitions home from hospital to community for a vulnerable, high-risk population. Through this brief presentation, we'll provide a high-level overview of our local journey to integrated care. We'll introduce you to our hospital to home work, and then dive into the specifics of our practical and participatory approach to creating an evaluation framework for this work, starting with our logic model and theory of change. We'll finish up by speaking about the relevance of this work to our organizational strategy, and more broadly, strategy work related to these types of programs in our area. So who or what is CHATS? CHATS is a large community support organization that supports about 8,000 older adults and their caregivers each year. We're a nonprofit charitable organization that receives about 85% of our funding from government sources. We operate in a mixed urban, suburban, rural part of Ontario, Canada, Canada's largest province, and we're situated in the central part of Canada, covering a geography of over 2,600 kilometers. The organization supports a diverse population with a wide range of needs, from independently living well seniors to individuals requiring 24/7 care in the community. So how did we get here? What was our journey to integrated care? Our journey started in 2009, having both deepened and broadened over the last 14 years, as our provincial directions have evolved along with our legislative, regulatory, and policy framework. We started with a very practical solution to a historical problem. Older adults were being sent home from hospitals in taxis or with family without any immediate support on the other side. There was no catcher's mitt. As a result, many discharges failed within the first 24 hours. As part of Ontario's aging at home strategy, CHATS began to think about how could we physically get older adults safely home from hospital, make sure they had all of the necessities they needed to get settled, and most importantly, to stay home. We designed the Home at Last program, we call it HAL, to do just this. Transport people home with a skilled personal support worker, provide up to 3 hours of settle-in service that could take place over a number of days, and connect people to longer-term community support. It's through this work that CHATS first connected with Siu Mee and her research on integrated health and social care. Fast forward 10 years, and in 2019, in the context of an emerging framework for integrated care in Ontario, a more comprehensive approach was envisioned by one of our local hospitals. CHATS stepped up to the plate to be part of this journey. For the remainder of the presentation, we're going to focus in on this more comprehensive model of integrated hospital-to-home transitional care programs, designed to create a better experience and better outcomes for older adults and their caregivers. The goal was to create an individualized approach where partners from different parts of the healthcare system would work together right from the point of discharge planning over up to a 26-week period to ensure a person-centered, durable discharge. These programs were funded through fixed bundles of funding, where providers had the flexibility to work in a way that they believed would achieve the best outcomes. So this was outcomes versus activity-based funding. Programs have expanded to include a broader range of services, supporting a more complex population, people who would typically be at risk for lengthy hospital stays and have significant barriers to discharge. CHATS works with the hospital, with a large service provider that provides nursing, rehabilitation, and personal support, other community agencies, and we work with these partners right from that point of patient identification through the full 16 to 26-week journey in the community. The program process has been pictured in the slide that I'm sharing with you now. This was created by one of our partners, South Lake Regional Health Center, and depicts the process of their South Lake at Home program. So why the evaluation? Why did we start this part of the journey? Each hospital was actively measuring a broad range of measures, typical measures that hospitals tend to look at: patient family experience, provider experience, cost value, impact on repeat emergency department visits, those kinds of things. And the results were excellent. Within the first 8 months that one program operated, almost half of the 144 patients had 0 alternate level of care days. That is, they went home exactly when they should, when they were ready to. The overall alternate level of care rate reduced from 14.2 to 1.8 days, saving the hospital almost 2,000 days in the first 8 months. But there were no mechanisms to measure the impact of the unique and important contributions that each individual partner was making. No mechanism to assess the outcomes of the work that CHAT specifically contributed from the perspective of our clients, the system that we worked within, and our organization. We needed a way to demonstrate the impact on government priorities and systems level pressures. We wanted a framework that would help us to understand both qualitative and quantitative contributions of these programs. We felt that a solid evaluation framework would help us to understand the impact of community support services on the transition of clients from hospital to community, and specifically on the ability for them to maintain their tenure in the community. With that, I'll turn it over to Siu Mee to talk more about the details of our process.
Thank you, Nancy. As mentioned, my name is Siu Mee Cheng, and I am an instructor at Toronto Metropolitan University. I recently completed my doctoral studies in integrated health and social care. I'm also a consultant as well as the executive director for Street Haven, a women's not-for-profit agency that provides shelter, supportive housing, as well as addiction services. So for my portion of the presentation, I'll be diving a little deeper into the methodology as well as the results of the logic model and theory of change work that the CHATS team had undertaken. So to begin, a total of 19 CHAT staff were involved in the exercise in developing an evaluation framework. The 19 staff really represented a cross-section of client-facing staff as well as management and the executive team, and they came from different programs across the entire organization. The team undertook a training session around logic model and theory of change models, and then undertook 2.5 days of logic model and theory of change work in order to develop several deliverables. This first deliverable was the logic model itself. And for those of you who may not be entirely familiar with logic models, they're simply an illustration of programs showing a program's inputs, activities, and outputs and how they link to intended or desired outcomes at the short-term, intermediate, and long-term basis. For the hospital to home program, as you can see on the very far left, these are the various inputs. I just wanted to touch very high level some of the activities that were core to the program. They include care coordination, assessments, referrals, Meals on Wheels, running errands, as well as providing transportation to clients. In addition, there's another bucket of activities that are targeted for the caregivers, and they include counseling, education, training, and referrals. These two activities in turn result in various outputs as well as outcomes, and they're color-coded on this logic model. So the blue corresponds with the activities related to the client, and the purple represents the outputs and outcomes related to the activities related to the caregivers. And the pink in the middle, as you can see, are outputs and outcomes that target both the clients and the caregivers. In addition to the logic model, there is also a theory of change model. And the theory of change model, again, for those of you who may not be entirely familiar with that, is a narrative that helps to explain the links between activities and outputs of a program in terms of the intended and desired outcomes at the short-term, intermediate, and long-term basis. And they really speak to the causal pathways and the causal mechanisms behind how those activities and outputs are able to result in the desired outcomes. The last set of deliverables that the team had been able to develop were a set of metrics related to the various parts of the program. They included metrics related to the activities, to the outputs, to the and to the short-term, intermediate, and long-term outcomes. I will not be going into depth to any of these metrics, but I did want to highlight, just as a nice contrast against the metrics identified by Nancy when she was talking about some of the successes as seen in the hospital, some of the metrics that are of interest for CHADS as a community-based agency. And if I can draw your attention to the short-term outcomes, you can see, in addition to the readmission rates, which are good proxies of client outcomes, the team was particularly interested around metrics related to caregiver strain, to caregiver stress. And when you look into the intermediate level, you can kind of see some of the other metrics, including social connectedness, coping skills, return to work. These metrics have a more focus around the individual and the whole person, as opposed to simply the system and the healthcare processes themselves. So let me jump a little bit into the causal mechanisms behind the program as identified by the CHADS team. The program ultimately has a key goal, which is to ensure that clients and caregivers are able to achieve or exceed their pre-hospital physical, emotional, and psychological wellness. And this is done by allowing the clients and the caregivers to attain a set of skills, competencies, and knowledge that allows them to reach a point of independence and confidence in order to self-manage their own health and care. In addition, this program also allows the clients and the caregivers to acquire a set of skills to manage their own stress in order to ensure greater independence. One of the key activities that I mentioned earlier was around care planning. This set of activities provides clients and caregivers with the knowledge to integrate back into the community and access the needed services, and empowers the clients and the caregivers into navigating the various health services and resources, thereby leading to enhanced self-esteem. The clients are able to access more services that supports them in staying in the home, and thereby reducing the unnecessary emergency department utilization. And this ultimately helps to improve health systems performance. In addition, the hospital-to-home care planning also results in decreased social isolation. The clients are able to navigate and access external community-based resources, thereby increasing their community engagement. And the earlier home returns leads to reduced anxiety over the stresses associated with the transitions from hospital into home. And this reduced anxiety further minimizes that need to get to the emergency department because they feel ill-equipped. The last set of outcomes are related to the caregivers, and the hospital-to-home activities around emotional support and counseling that's offered to caregivers allows caregivers to build the necessary coping and resiliency skills. This enables better mental health, thereby leading to decreased social isolation. And because the caregiver feels more stable and independent, they're able to incorporate those more healthy outlets to alleviate stress because they have acquired those coping and resiliency skills. And this allows them to feel more comfortable to return back to work sooner. So with that, I'm going to turn the stage back over to Nancy and have her let you know, inform you about what the next stages are with CHADS.
So what is next? So where do we go from here? Since this work was completed, we've had the opportunity to include this evaluation imperative in our organization's strategic plan refresh. We've also had the opportunity to work with external experts to develop an internal strategy related to alternate level of care that would support our work in this area and help us to find resources. And we're now actively in the process of working to identify a funding source to undertake the evaluation itself. More than anything, we want to continue to learn and to develop as an organization. We want to be able to have a greater impact on those we serve and to be able to objectively tell our impact stories through effective evaluation. We'll turn to the next. Thank you. So thank you so much, everyone, for choosing to participate in our presentation. Our contact information is there. You can contact either myself or Siu Mee. Please feel free to reach out, and we'd be more than happy to respond and to have more conversations around this topic.
Great, thank you. I'm feeling old listening to your presentation. In 1987, I won't take long with this, I was involved in developing a program for children with type 1 diabetes in Washington, D.C. And we sat down and led by Alan Glasgow, the endocrinologist, we decided they needed a dietitian, they needed a social worker to make sure housing and food was taken care of. We needed to make videotapes for the schools to understand the kids. We had to make sure they all went to summer camp so parents get 2 weeks off from taking care of the kids with diabetes. We didn't have a plan to do that, and that's what you have now. We didn't have a logic model, and we didn't. But after 4 years, we reduced readmissions by 60% in our population. And in a fee-for-service environment, we went from breaking even to losing $500,000 a year. Because when kids don't come to the hospital, you don't make any money. But my point is, it's just wonderful to see how the models have evolved, how the thinking has evolved. It used to be when patients showed up in the emergency department, it was those patients or they were the frequent flyers, and we blamed the patient. And by gathering data, what you've done is you've shifted and shown that it is external variables to these individuals that we need to address. And that is the major shift I've seen over 40 years, appreciation. So thank you for your work. And any comments, now that I've taken up time, any comments from the panelists or attendees?
I have a comment and a question. So thank you for that. I think that sometimes, those of us working within the system sometimes fail to realize that there is a community that we also need to connect with. And I think your study shows that very clearly. And we've learned to appreciate that too, going at it from both sides, not just, one side. So I appreciate that very much. I wanted to ask you, so, you had the 19 your staff, so 19 staff involved in pretty much pulling together your logic model and, all these pieces. Did you at all involve some of the clients or caregivers in terms of pulling together some of those pieces that looks at what they perceive as important outcomes or metrics or measures from their perspective? I just wanted to find out a bit about that part of it.
Sure. So we didn't involve them directly in the design sessions for the logic model and theory of change. We were under this incredible time crunch, not that that's an excuse, but we, had a little bit of year-end money and put this together in a very short period of time. But what we did do, because many of the people around the table were client-facing workers who were working directly with individuals in the home, was that they actually had those conversations with people during their regular interactions. They asked questions, they gathered input, and then they brought that input to the table. So while, not formally, the kind of, client and family-centered process that we might envision and that we will use when we do the actual evaluation, we do feel that we got a reasonable amount of input, leveraging the client-facing staff around the table.
Okay, thank you. Yeah, I just wanted to point out that I've done a little bit of comparative analysis in that regard and found a huge difference when I had upfront. That's why I have a patient family advisor working as a right-hand person, because there's a difference in terms of looking at those pieces right up front. I think you're going to find that, and I'd be interested to follow up with you to see if there is a change in that perspective and lens around what pops out for your logic model and your evaluation as well, because sometimes care providers bringing that information back, translation is different, all kinds of things turn and churn and are different. I mean, I've done that myself when I've done that for our residents or even my own family. So I think, I'd like to see what pops out as something that might change in your change theory and your logic model as you progress, just out of curiosity. So thanks for that. I'll stay connected. Thank you.
Thank you for that. Yeah, and as you were presenting, I was thinking the same thing. I was really wanting to follow up with you and to learn about how you implemented what sounds like a really comprehensive co-design process. So we'll definitely stay connected. I'm interested in learning more.
Okay, thank you. We have 3 minutes left. I want to first of all thank Darren Curran from IFIC, who was able to take care of our requests 15 minutes before this started and has kept us all connected and kept us running smoothly. Technology is grand, but having someone who can coordinate it and keep it running is even better because it is useless unless it runs properly. So thank you, Darren. And then to each of our presenters, I'm not going to go through all your names again, but thank you all. And to the attendees who stayed with us for the whole time, I hope you found this valuable. All the presenters have indicated ways they can you can get in touch with them, and let's keep this dialogue going across borders, across continents to address these issues. And that's, again, the major role of IFIC. So thank you again. Any final comments from anyone before we sign off? We have 2 minutes left.
I guess I would say before we leave, just especially given all the different perspectives, is that I think that there is a slight orientation around transitions in care from a very acute care lens. And just to kind of state that the community-based lens is important. I think you had said earlier, just, you know, once you discharge a client, they have a life after a hospital. And oftentimes that is sometimes forgotten. And if we forget that from a systems perspective lens, it ultimately comes back to us as healthcare providers, as administrators. I know certainly in dealing with homeless women, if they're not discharged properly, they're only going to end up back in the hospital or in the police system or the justice system. So these are societal concerns that we all should have. And I think it's, you know, it's life beyond the hospital is really where it's most important.
Thank you. I think a great closing comment. Thank you. Thank you all. Hope to see you all in the future.
Thank you.
It's been a pleasure meeting you. Thank you.
Sure.
Bye-bye.
Bye-bye.
Bye.